All right, another Thursday, so let's get to it. We have, what do we have? 5 studies on the docket. These are going to be pretty quick, a little bit quicker than normal. And a lot of this is either revisions of old information we've gone through, just highlighting it in a different way, or they're just studies that give me another chance to speak on a topic we've talked about in the past. You'll see. So first one, exploring the effects of manual therapy on tinnitus and dizziness, a randomized controlled trial. Basically, in a hospital setting, after they really screened out any other potential cause for the dizziness and tinnitus, making sure it wasn't anything pathological, scary, or where this wouldn't have a possibility of working because it's a different pathology, they wanted to see if manual therapy done in specialized physiotherapy clinics could affect tinnitus in patients that suffer with tinnitus. And that's a big deal because tinnitus is pervasive and there's not many things that quote unquote treat it. What they think or what they thought during the study was that muscular issues in the neck happen to be the most likely cause of a particular type of tinnitus, somatosensory, and dizziness. And could they modulate it? Well, yeah, some patients can seem to modulate it through movement and palpation. So what if we just take it up a notch and have a physiotherapist and other specialists do it? And what they found was manual therapy could alter some of the things they were measuring, such as pressure pain in the head and neck muscles, as well as tinnitus and dizziness in the intervention group alone. So it's possible that, barring and ruling out any other cause of tinnitus and tinnitus with cervicogenic dizziness, that manual therapy could be beneficial for flare-ups or when you're really suffering with that tinnitus or dizziness. So yeah, I mean, it's kind of straightforward. This is something that we see. It's something that I taught when I was teaching as far as cervicogenic vertigo is concerned, that manual interventions to help recombobulate and reestablish a good connection between the neck and the brain really helps these conditions. So again, I'm going to say it this way for everybody out there. Ruling everything else out. So you need to have a good exam, a good doctor, a good workup, all of this, because you want to make sure you get these symptoms and diagnoses correct. If you're ruled in to have a cervicogenic dysfunction contributing, leading, or causing issues such as vertigo, dizziness, and now potentially tinnitus, having some manual intervention in the neck can help reestablish communication between confusing signals the neck is feeding the brain and reestablish a new baseline normal that will help the brain, for lack of a better word, it's like restarting your computer. It'll reboot, and all of those senses that the brain has to juggle and give you a mental picture of, like where are you at in space, what's going on, will become a finer tuned picture. And it's all right, let's take a step back. A lot of what causes these symptoms is part of your vestibular apparatus being off kilter, because you need your eyes, your inner ears, and your neck to all work in harmony on top of the rest of your body to really establish where you're at in space. If any one of those input mechanisms are thrown off, the brain gets a fuzzy picture and you have some of these symptoms develop because it's trying to figure out where it's at in space. So if the neck is feeding bad info to the brain, treating and taking care of the neck can alleviate some of these symptoms as long as you've got the diagnosis correct. There, I got it back in the end. Next study, acute effects of neck muscle fatigue on masticatory muscles in bruxism, so grinding your teeth. So they wanted to see, is there any correlation between neck muscular fatigue, so tiring out the neck, and the jaw going through an altered, basically an altered biomechanical state. Does your neck, when it gets tired, affect how your jaw works? Answer, yes. Let's jump to the conclusion on this one. Neck muscle fatigue acutely alters the mechanical and blood dynamic properties of masticatory muscles. These findings support the need for neck assessment when we're dealing with jaw issues, and this one was bruxism. And this is something I've seen in clinical practice for years, and it is often the missing link, is we get too focused in on where the problem is because that's I mean, like, it's natural. I hurt here. I have jaw issues. So you're going to focus on the jaw. What's often left out is the neck, and potentially vice versa. Some people going through stress develop neck tension once in a while. You have to take a look at the jaw as well, not because it's going to be the panacea, like, oh, I've had neck pain for 20 years. This is the one thing that's no, no, no. That's not what I'm saying. I'm saying once in a while, what walks through my clinic is adding in some jaw work and some jaw movement, some jaw exercises, and jaw manual therapy can act as a catalyst to help get through either a chronic issue or a flare up, because that's where the body is most reactive to that person's individual neck complaint. So it's a two-way street. And this is something, again, I've seen in clinical practice, I've dealt with. And it's interesting that they're, in my opinion, from my experience, it's adding in bruxism. Like it makes sense now that I'm reading. It's like, people like patients I know do brux at night. And very oftentimes it's one of those things where they're just given a mouth guard or they're given other means to reduce the bruxism. And I usually will understand that it's more of a, not just a dentist, but what's the word? What's the profession I'm thinking of? Orthodontics. Basically the doctor that specializes in the teeth. Oh, this is bad. And it's not just dentist. It's something else. It's where you see like the surgical centers. Well, I'm going to keep moving, but I'm not going to edit this because you get to see, I forget names too. They basically said that after they fatigued the neck, pain-free maximum mouth opening was significantly decreased. So the ability for a person to open their mouth without pain beforehand might have been a full opening. After they tired out the neck, they can only get so far before it's like, ooh, that hurts a lot sooner. So your mouth and neck seem to, like every other part of the body, have a pretty close-knit relationship where when the brain has to organize what it wants to do, how it wants to do, when it wants to do, if you don't have the resources available in the neck, you're going to change how you work your jaw. Just like I've seen where if you run out of resources in other parts of your body, other joints are affected. So this one shouldn't be as surprising as it was to me, outside of the fact that it mentions bruxism and a few patients come to mind. So I'm going to keep this in the back of my brain for those patients to really start working on, at least from this study, it seems like endurance. So the longer we can postpone that neck muscle fatigue, seemingly we might be able to do them one better, in addition to things like their mouth guards. Long rambly way for me to say, cool for me. I learned that, or reinforce that my patients with bruxism, I should really work on neck muscular endurance on top of them getting a mouth guard. And you kind of got to see me and my tired little hamster in the brain work through a lot of things live on camera. Let's move on and keep going. Usual care for low back pain in the United States, emergency departments over 6 years. Couple things, caveats about this study. This is an emergency department. It's going to see certain things, which means they're going to see certain levels of pain. Like nobody's going to go in for a 1 out of 10 level back pain unless you have something really freaky going on. So I can already tell you that before we go through this study, the pain levels are going to be high. And the purpose of an emergency department is, this is going to sound callous, but are you dying? If yes, we will make sure you don't to the best of our ability. If not, it's not the emergency department's job to do much more than triage you, okay? It can't be anything else if it wants to do fantastic work keeping you alive, okay? It's like triage diagnostics on steroids. That is the purpose of the emergency department, because it has to catch anything at any time over 24 hours. What could come in, and is it going to kill the person, okay? So already we have people that are concerned because their low back is probably in excruciating pain. The emergency department's job is just to make sure you're not dying. And we see some trends over 6 years. And the purpose of this study was simply to say, it's a good resource for us to use data to potentially improve interactions in the future. That's the purpose of the study, okay? So first up, results. Over 6 years, there were almost 53 million emergency visits for low back pain. The pain was a 7 out of 10. Kind of told you so. 13% arrived by ambulance, 40% were related to injury or trauma. So we already understand what is potentially causing that back pain. We're going to skip waiting room time. Here we go. In 2016, about a third of those low back pain patients got opioids. That is something, just like surgery, we want to avoid as much as possible. It is a very fine balance, like with surgery, basically the whole opioid thing is a very fine balance, because when we talk about and debate opioids, obviously part of my professional capacity, on top of doing no harm, on top of the conservative muscular health viewpoint, the vantage point, I of course am going to try and do as much as I can to avoid opioids as much as possible for me, my patients, everybody else, because they do have significant side effects, significant mortality associated with them, significant addictive properties to them for the wrong people. And so you really want to make sure that it is a case where nothing else is actually going to mitigate this person's pain. So we have to be very cautious in our approach. But I also understand that there is the scenario where, essentially you can't do anything else except introduce things like this. So I want you to understand my position first and foremost. I want it to be just like surgery, the right thing for the right person at the right time, which in my opinion, as of right now, it is still overprescribed. You will find the person, whether it's in person, in an online forum, on the news, where it is for them. Obviously, there is a place for them, but it is not en masse for non-specific low back pain, for non-intractable. I always get those confused. Basically, the word is intractable, which means the pain cannot be taken away or you cannot mitigate the pain at all. So there are cases for it, but just like a lot of surgeries that I see, it is the wrong person at the wrong time. It's too soon and too overdone, too sought out. Okay. So first up, in 2016, they were prescribed in about a third of the cases. And by 2022, opioids, the administration went down. Now, we could speculate that it was just administrative and guideline based that it was reduced. We could presume that there were certain things that happened in 2020 that may have skewed some of these numbers, data collection. We don't necessarily know entirely what the illicit market could have done as far as reducing the need for prescriptive opioids. There's a lot that could be done. Now, I'd like seeing a reduction, but I'm not going to assume the number is actually as low as that until we get more time under our belt to essentially see, because there are a lot of confounding factors between 2016 and today. Like a lot of things tossed a lot of this data up. And as much as I like the number, I'm going to take it with a grain of salt and be skeptical on it. That's what I'm going to say about it. Now, radiographs were obtained in 40% of ED visits, which, again, if you had trauma, that is an indicator for a radiograph to rule out any other potential abnormality, including fracture. And if you rule that out, the patient still has symptoms and issues, you may want to get something like a CT or MRI, because what if they have something visceral, soft tissue based, which can contribute to low back pain. And both opioid prescribing and radiographs were most prevalent in patients 75 years or older. So again, when it comes to radiographs, that is the demographic you want to be a little bit more willing to take an x-ray or image of, just because of their age and other potential things going on in their body at that time. And again, opioids, part of that may just be human nature. You want to take care of this person. There's not much you can do for somebody that's in pain, probably not ambulating as much because they're in pain. They are older. They probably have a lot of co-founding and compounding diagnoses and comorbidities. So there may not be that much in the repertoire, especially in an emergency department, that a person can do besides prescribing opioids. Does that still make it right? No, not in my opinion, but it is something we want to understand. So, and again, as I prefaced this study, it wanted to update and what the usual diagnostic and therapeutic care was in the emergency department for this, which may be a benchmark for quality improvements. If you're going to try to avoid unnecessary emphasis, unnecessary surgery, and unnecessary prescriptive opioids, seriously consider conservative means. I'll just toss in my clinic. If you're watching this video, please consider coming to my office, seek care. I will do everything in my power to not let you be a statistic in a situation such as this outside of extenuating extreme life circumstance. Okay. All right. Last two are a bit quicker, I promise. Efficacy of manual therapy on shoulder pain and function in patients with rotator cuff injury. This one's a systematic review. Like every other study that talks about manual therapy, exercise, etc., it is the combination of them both that yielded the best results. So where does it start in this one? Here it is. Compared to placebo, just manual therapy couldn't relieve pain. We've seen that in other studies before. Its impact on functional improvements appears limited in isolation. Combining manual therapy with exercise had significant advantages over exercise alone. We see that in a myriad of other studies as well as combined therapy contributed to both pain reduction and functional enhancement. Furthermore, manual therapy combined with multimodal physiotherapy showed additional benefits in pain reduction and functional improvement compared to multimodal physiotherapy alone. So again, the more we're able to take a multimodal, multivariate approach in conditions that seem simple on the surface, but humans are complicated, hitting this generic diagnosis from multiple angles is still showing to be the best bang for the buck and in the best interest of the patient. So take that and do with that information what you will. We happen to do all of those in our roof. I'm just saying. At least as far as the manual therapy and rehab goes. Technically speaking, I shouldn't just say that when you talk about multimodal physiotherapy, because that could be anything under the sun, in which case I may not do it. But manual therapy plus exercise is something we specialize in this office to get you through these chronic issues that nobody else can, and to avoid the surgeries and unnecessary prescriptions. We try and make sure that we do what the evidence says that is the best interest of our patients. That is still, once again, according to this study, a combined approach. That's what we do here, and we're willing to work with anybody else to add more pieces into that puzzle that is you. So if you have a coach, medical doctor, personal trainer, anybody else that helps you get where you're at, we will gladly work with them. All right, last one. Let's end this bad boy. Optimal dietary patterns for healthy aging. It's basically what we already know to a degree, but let's sum it up again. Where is it? Here we go. Higher intakes of fruits, vegetables, whole grains, unsaturated fats, nuts, legumes, and low-fat dairy products were linked to greater odds of healthy aging, whereas higher intakes of trans fats, sodium, sugary beverages, red or processed meats were inversely associated. So if you eat a dietary pattern rich in plant-based foods with healthy animal-based foods, you have a great chance of aging very, very well. There is a lot of debate between fad diets and essentially extremist versions of fad diets. So you have what has been around for years, veganism, what is on the newer ticket carnivore, we have keto, we have a whole bunch of diets out there that, frankly, the human body is very, very adaptable to the point where outside of a few diagnosable conditions, strict adherence to a fad diet is not typically in the best interest of a majority of patients because they are difficult to adhere to. Now, if you have conditions such as SIBO or SIFO, small intestinal bacterial, or now they're looking at fungal overgrowth, yes, we'll probably want to do low carb for a while we're getting through the actual SIBO, because a lot of those things will feed off of the carbohydrates. So there are a time and place for modifying the diet if you have certain conditions, whether they're metabolic, whether they're inflammatory, etc. Okay. Taking those out of the way, healthy aging is a well-rounded diet that includes all of the foods available to us. And some of these things you may just be like, well, whole grains that's not just bread. That is quinoa. That is farro. That is, I'm blanking now. uh, couscous. That is amaranth. That is a whole bunch of different types of grains that have different minerals in them that actually can help. What about meats, red meats, processed meats? Well, it's like I gave one on processed meats. That one does have a lot of sodium, a lot of nitrates, and I will say mechanistically, yeah, this one's not as good. But you know what? Again, red meats, it even says moderate inclusion. The dose is in the poison. Like, I love steak. I'm not telling you not to eat steak or bacon for that matter. It is just the distribution. That's all. So, yeah, same thing with sodium. Oh, I got to cut out all sodium in my diet. Well, no, just recognize that a lot of the current processed foods overdo us in sodium. So again, dose is in the poison, or poison's in the dose. Sugary beverages, yeah, not much I can do on that one, especially sugar added things like sodas. There was a study, I think last year, that showed, diet soda, even this is going to get a few people angry on here. Diet soda actually contributed to weight loss more than the pure sugar version. And the people that are concerned about the artificial sweeteners, whether or not those are in the doses deleterious to our health compared to their alternatives, which is the full sugar version of the sodas themselves, the diet sodas actually led to a reduction in weight, which in and of itself, so if you want to lose weight and you're willing to, go from a pure soda to a diet soda, you actually had a better chance of losing weight or a bigger weight loss compared to the control. And that in and of itself could be argued to be offsetting the artificial sweetener hit, so to speak. Like, getting more weight loss was better for your health than the artificial sweetener was bad for it. So it's like a net positive if we want to look at it that way. But yeah, again, it's reiterating what we're finding in the evidence over and over and over and over. This type of diet appears to be, on average, the most health promoting, healthy aging diet out there. And again, that is outside of pathology or conditions. Like I talked about, if you have SIBO, we'll modify it. If you have Crohn's, we may modify it. Celiacs, modify it. Like, use this as a base, modify from there, work with a professional if you have an issue such as that. But I'll tell you what, this Thursday, boy, was I rambly, but I'm not going to edit it. I'm not going to do a take two. I would much rather you see what is real than a extremely edited, modified, makes me only look good version. Like, this is me. This is how I will think. This is how I talk. And Yeah. So till next week, hopefully this one, hopefully this rambling roller coaster of a Thursday, you learned something. I know I did. Till next week.